211 summer session. My name is Samantha McCoy, and I'll be going over HIV and AIDS with you. HIV and AIDS is a common chronic disorder of the immune system. HIV is the human immunodeficiency virus. HIV weakens the client's immune system by destroying the CD4 T cells. Acquired immune deficiency syndrome is AIDS. CD4 cell levels in the immune system drop significantly, which exposes the client to opportunistic infections such as bacterial, fungal, and viral infections, as well as cancer and other diseases. Human immunodeficiency virus, HIV, can progress to AIDS. Here's a infographic that shows you exactly, it gives you a visual aid on how it progresses. So HIV, once your body is attacked by the virus itself, within the first 2 years, your CD4 cells are still very active, and it's keeping the viral load down. So as the years progress, without any medications, eventually the viral load increases significantly and your CD4 cells decrease significantly, which then changes it to AIDS. So it starts off as a virus, and then it progressed to acquired immune deficiency syndrome because your immune system is deficient because it has such a low CD4 cell count. So now we'll go over the HIV infectious process. So your CD4 T lymphocytes have two receptors along the cell membrane, which is your CCR5, your CXCR4 receptor, co-receptor, and your CD4 receptor. So with the HIV virus, what actually happens is it binds with those receptors. Once it binds with the receptors, then it docks onto the proteins of your CD4 cell, and then it hijacks those cells, and it allows the virus to host interaction, allows HIV to invade the host cell and replicate. That's why we can call HIV an intracellular parasite, because it works by hijacking your CD4 cells and depositing its genetic information into it, and then hijacking it and using the CD4 cells' genetic information to reproduce itself. So this is the life cycle of HIV. Here's a visual representation of it. So here's your HIV virus itself. So then it gets close to your CD4 cell, and then it docks onto the CD4 cell, and it opens the cell wall, and then it allows its genetic information to enter the nucleus of your CD4 cells. And then it injects the core of the HIV virus. So then it opens it up and it uncoats, and then it uses this genetic material, the RNA, converts to DNA, and then your DNA then enters the nucleus of your CD4 cells, which in turn integrates, and then it copies and transcripts it into additional genetic material, which is translated into creating another HIV virus. So then it has this protein modification, and it produces genetic material, and then it assembles a core around it, and then it buds off, and then here's a whole new HIV virus. The important thing about knowing the life cycle of HIV is where the different sites for the action of anti-HIV therapy can occur. So your antiviral medications can occur. So here at your entry inhibitors actually work by preventing the virus and the host from interacting. So it stops that connection, that attachment, and that fusion. So your fusion inhibitors, so if they do have an interaction, what will happen with your fusion inhibitors, it will prevent it from actually fusing itself to your CD4 cell. Your reverse transcriptase inhibitors work by preventing copying and morphing into the host cell's genetic material. So HIV's RNA cannot change into the cell's genetic material. Okay, that RNA is being prevented from converting into the DNA of your CD4 cells. Those are your reverse transcriptase inhibitors. That's how they work. Your integrase inhibitors work by preventing the virus from entering the host cell's nucleus, the nucleus here, and blending in with the host cell's DNA. So it changed from the RNA material, converted to DNA, and it made the DNA look like the DNA that's actually located within the nucleus of your CD4 cells. So your protease inhibitors work here by preventing the virus particles, these particles here, from reducing into smaller functional pieces that would have formed into new virus particles. So it prevents these particles from forming into new particles that can then be protected in the core of the virus and then bud off into a whole new virus itself. So the effects of an HIV infection, again, just to repeat for retention, your CD4 T cells become an HIV factory. So they make new viral particles daily. And then gradually your CD4 T cell count decreases. And then your viral load count rises because they're taking over. The HIV cells are just taking over. It's going in, making the CD4 cells DNA replicate it, and it's created more, and it's going on and meeting up with another CD4 cell and doing the exact same thing over and over and over until it depletes your CD4 cells. So as a result of that, your immune system weakens. But one thing to note is that everyone that has AIDS has HIV, but everyone with HIV does not have AIDS. Okay? So if HIV has not progressed to AIDS, they don't have AIDS. But if HIV has progressed to AIDS, they always have HIV because that's how it progressed. You first have to have been infected with the HIV virus. Then the HIV virus has to overwhelm your body's immune system, your CD4 T cells, enough that they're very limited, and that there's more viral HIV viral cells or viruses detected in your bloodstream than there are your immune system cells. So that's the difference. So initial presentation for HIV, people can present with a flu-like illness, and it's just what it says. You can have flu-like symptoms like fever, chills, a rash, night sweats. You can be fatigued, muscle aches, sore throat. You can have mouth sores, and your lymph nodes can become swollen. So these symptoms can last anywhere from a few weeks to several days. So during this time, it's important to note that the HIV infection may not show up on an HIV test, but people who have it are highly infectious and can spread the infection to others. So if someone knows whether they've been exposed or feel that they've been exposed, it's best for them to remain abstinent and try to limit exposing anyone else to the virus until they can be tested and confirm whether they actually have HIV or not. So there are several places, and you'll see that in the notes in the PowerPoint slide, that you can get free confidential testing. Of course, we want to be aware of that in our clinical area where we're working so we can give our patients the necessary information to make educated decisions on whether they want to be tested or not, especially if they've had a recent exposure. There's also home testing kits that are available for purchase in most pharmacies. And what you do is you go and you purchase the kit, you take the swab, do a sample of your oral mucosa, and then they seal up the packaging and send it off. And then they're anonymously given a number that matches that packaging, and then they can call with the results, or the results can be sent to them. And the only way to determine whether a person has HIV is to be tested. There are no specific signs and symptoms that you could see that says, oh, yes, you have HIV. Because again, as it's stated here in the slide, the initial presentation is just flu-like symptoms. So for HIV, there's different ways to classify clinically whether you have HIV. So stage zero, according to the CDC, is when a patient develops a first positive HIV test results. And this usually occurs within 6 months after the negative HIV test result or that initial exposure. So the patient's stage status change does not occur until 6 months have elapsed after the initial stage 0 designation, even when their CD4 T cell counts are decreased, or they have an AIDS defining condition. So from their within 6 months after a negative HIV test results. So if they've been exposed to HIV from a partner or a blood transfusion, however they've been exposed, once they went to their provider and let them know that they've been exposed and they want to get tested. So they get tested, it comes back negative. So within 6 months, they need to have another test. And after that 6 months, or within that 6 months when they're tested and it comes back positive, that's considered stage 0. Here are some other categories in the staging system for HIV. So after they've been confirmed to test positive with HIV, the next laboratory evidence that signifies that they have HIV will be a CD4 count of greater than 500 or a CD4 greater or less than 29%. So that's their overall CD4 T cells. And they have no AIDS defining condition. That's considered stage 1. Stage 2, they have a confirmed HIV infection, and their CD4 count is between 200 and 499 units per liter, or their CD4 is between 14 and 28%, and they have no AIDS defining condition. Stage 3, they have a confirmed HIV infection. Their CD4 count is less than 200 units per liter, or their CD4's percentage is less than 14%, or they have an AIDS defining condition. When they have a stage unknown, they have a confirmed HIV infection plus an unknown CD4 count and percentage. And they have an unknown AIDS defining condition. So this is really important to remember the staging system for HIV, because that's going to determine the progression from HIV to AIDS. And that gives you a better idea of how that progresses. It's important to know that AIDS is classified as having a CD4 count of less than 200, or a CD4 of less than 14%, plus a AIDS defining condition, or a AIDS defining condition. So HIV diagnosis is done by a laboratory confirmation of the infection, either by antigen or antibody testing, or enzyme-linked immunosorbent assay, ELISA. A Western blot analysis is also conducted to confirm that someone has HIV. CD4 T lymphocyte count or percentage is also a determining factor in the laboratory blood test as well, to determine if they've been exposed to HIV. So they have a presence or absence of one of the 27 AIDS defining conditions. So those are the 3 factors that can help diagnose whether someone has tested positive or is positive for HIV. HIV progression can take months to years. There are personal life factors that can affect the timing of the progression. So the frequency of re-exposure, the presence of other STDs, their nutritional status, and their stress, their lifestyle stress. So also other health problems that are present too can be factors that have an influence on the progression of HIV. So 2, if they were transfused with HIV contaminated blood, if they've been re-exposed to HIV. So in the instance of a person is a sex worker, or they're exposed to someone who is HIV positive, their partner is HIV positive, and they're constantly re-exposing themselves to that status. So usually there's a slower progression when it's contracted from a single encounter. So if you're with someone and you find out that they're HIV positive and that was the only time that you were with that person, there's usually a slower progression to HIV. So the more your body is exposed to the HIV virus, the more opportunities the HIV virus has to enter your bloodstream. Okay, so HIV has been known to be a mutating virus. So the more you're exposed to it, it's a possibility that you can be exposed to various mutated forms of the virus. So that will increase the progression of actually HIV. Remember, they have that window from the stage 0 to stage 1. So the incidence and prevalence of HIV in the U.S., greater than 658,000 people have died of AIDS. 50,000 are being diagnosed annually. 1.2 million are currently living with AIDS, and that's according to the data received from the CDC in 2015. Worldwide, 2 million people per year are newly infected with HIV. 34 million deaths have occurred worldwide from AIDS since the start of the epidemic, and that start of the epidemic was the mid-80s. There are 37 million who are currently living with HIV, and that's according to the World Health Organization statistics. So, adult HIV is a serious worldwide epidemic. Approximately 36.9 million people are currently living with HIV, and that's the most recent data that we have, and that was from the UN on AIDS, and that was in 2018. Okay, now we're going to go and review health promotions and maintenance with our patients with HIV. And one thing to note is how it's transmitted. HIV is usually transmitted via sexual contact, parenterally, or perinatally. HIV is not transmitted casually. It's not transmitted by sharing household utensils, towels, linen, or toilets, or by way of mosquitoes or insects. So your parenteral transmission is through IV drug use. Part of that is done because part of that transmission includes not properly cleaning their works. What the works are their needles and their syringes and other drug paraphernalia. So it's important to educate our patients on needle exchange programs, knowing where they are located at in our areas, and encouraging them to not reuse needles, because that, especially if they have IV drug habit, we want to encourage them as much as we possibly can to get a new needle each time, so they won't be re-exposing themselves to HIV or constantly exposing themselves to HIV. Another mode of transmission is perinatal transmission, and that occurs across the placenta during pregnancy. The infant can be exposed at birth to the blood and vaginal secretions of the mom, and then they could be exposed after birth through breast milk. So education is key. If we have an HIV mom that we're working with, we want to educate them on how it can be transmitted to their unborn child and what can be done to prevent it, because currently there are prophylactic medications that can be given to the child once the child's born. And also there are means of testing to see whether the child has actually seroconverted once the child's born. So HIV, without treatment, it can make a person very sick and even cause their death. So learning about the basics is very important to for people to keep themselves healthy and prevent transmitting it to others. So it can be transmitted by sexual contact, sharing needles to inject drugs, mother to baby during pregnancy or birth or breastfeeding. And also, it's not noted here, but it's rare now because of the screening that they do for blood transfusions, that it's contracted by a blood transfusion. So HIV is not transmitted by air or water. It's not transmitted by saliva, sweat, tears, or closed mouth kissing, by insects or pets, by sharing toilets, foods, or drinks. So there's sexual transmission, or ABCs of safer sex. As far as transmitting HIV, the first and foremost, of course, is abstinence. If you're not able to be abstinent, you can be mutually faithful. So agree with your partner that you won't go outside of the relationship and that you're going to be faithful to one another. And then have consistent and correct use of condoms as a form of protection. And then if you are using IV drugs, you do not want to share your needles. And then you really just don't want to do drugs. And education is very important on preventing the transmission, sexual transmission of HIV.
Got home, and Jay said, "What's going on?" And I just went in my bedroom, and I picked a folder up, and I handed it to him, and it says, "What to do when you get tested positive with HIV." He threw it down, and he said, "Where did you find this?" And I said, "I just went and got it because I tested positive for HIV." And he just fell down on his knees and started bawling like a baby. And I said, "Jay, why didn't you tell me? Why did you lie to me?" He said, "I didn't lie to you. I told you I didn't have AIDS. I don't have AIDS, but I am positive." I said, "But Jay, we didn't use protection." I said, "You could have used protection. You didn't have to infect me." "Well, I don't like condoms." I said, "So you're condemning me to a life of HIV and AIDS? Taking my life?" I said, "If you wanted to kill me, why didn't you just take a gun out and shoot me?" Oh, that whole afternoon we sat and cried and talked and cried and talked. We stayed friends, and he would call me up and he'd say how sorry he was that he infected me. And I told him, I says, "Well, that's between you and God." I said, "I've already forgiven you." Even on his deathbed when I was laying, I kept saying a prayer that Jesus prayed for the people that was hanging him on the cross, and he prayed and said, "Father, forgive them, for they know not what they've done." And I just kept repeating that over. God, forgive him. He didn't know what he was doing. God, forgive him. And I don't know why I kept praying that, but I just kept praying it and praying it and praying it. So. I asked my sisters, I have 3 sisters, I asked them to come to Portland to visit me. 2 of them came. And the next day I got phone calls. One of the sisters said, "Well, I'm sorry, but you can't come back in my house anymore." And the other sister said, "Well, after you leave, I have to sterilize my house. So it'd probably be better if you just didn't come around." I said, "Okay." Sometimes it just gets too weighed down, and so I go to church and pray and give it all to God. And it just takes the weight off my shoulders. It's just unbelievable how light you feel when you walk out, when you turn it all over to God. Sometimes I need a big shoulder to cry on, and I don't have a big shoulder to cry on. We were in church, and this young lady, she said, "God wants you to go up and ask specifically for what you want." I turned around and I went back up. I told my pastor, I said, "I want God to heal me from AIDS." And he put his arms around me and put his head on my shoulder and bawled. And just bawled. He must have bawled for 5 minutes in front of the church. He just sat there and bawled, and he started praying for me. Support from my pastor and his wife are just phenomenal. They just embrace me with their love. And that's how I feel with God. The minute I walk in that church, I usually walk in and I go to singing, Lord, build a fence all around me every day. Lord, I want you to protect me as I travel along my way. I know you can, I know you will. Oh, yeah. Fight my battles if I be still. Lord, build a fence all around me every day. Oh, yeah. God has built a fence around me. He's, and I say that fence because it's His embracing love that I feel wrapped around me. I don't let anybody outside that fence. I don't let the negative come in anymore. Sure, there's a lot of negativity out there, but it doesn't have to come inside me anymore. Two months after the baby was born, she finally broke down and said she didn't want to see the baby anymore. She didn't want the baby around her. She didn't want to be a mommy to her. So for 2 months, I took care of that baby day and night. And she said she was going to give the baby away. And I says, I want her. And she says, no, I don't want anybody around me to have her because I don't want to see her. I said, fine, I'll move away from you, but I'll take the baby. You don't have to see me either. I said, from this day forward, you might as well figure she's my baby and I will treat her that way, and I don't want to hear anything else from you about it. And I've had her ever since. But talk about changing your life and having a baby at 53 years old, and here you got a newborn baby. Wow. Especially when you have AIDS at my age, along with other medical issues, and I get so fatigued. 3 years later, we've made it through it, but she's my great-grandbaby. She's not just my granddaughter, she's my great-granddaughter, and she's been a blessing to me, and I feel like it's been returned. I've been a blessing to her because I give her so much love and attention. Since Ariana's been around, I don't get as depressed. I can't be depressed and raise a child and raise a baby. If she wasn't here, I don't want to imagine it. She is my alarm clock every morning. She's the reason I go to the store and buy milk. She's the reason I cook. I don't take very good care of myself when it's just for me. She knows what they're going to do when I walk in that room. And she'll sit down on the bench by me and, it's going to be okay, Grandma. And she'll pat my arm or pat my face and stand up and hug me. And she's just so compassionate, just so full of love for me. And I worry about the AIDS, especially since my T cells has been so low. It's been 15, almost 16 years now. I have to keep living. I have 2 daughters, 7 grandchildren now, and 2 great-grandbabies. I keep living. And I have the faith. I have the faith that they're going to take my blood and they're going to come back out and they're going to say, there's no sign of this virus in your blood. And I'm just going to start bawling like crazy. because it's going to happen. Everybody looks at me like I'm nuts when I say that to them, but it's going to happen. Something else might wipe me out, but AIDS ain't going to wipe me out. It's not going to wipe me out. It's not going to do it. I'm not going to let it, and God's not going to let it.
We had no idea what patients were presenting with, and we would have patients come in and the biggest diagnosis was fever of unknown origin, and we would get patients who would not survive that.
There was little to no testing, and the way people found out whether or not they were HIV infected, people would donate blood and they'd figure out, okay, well, I can't donate blood when I go back, so then I have HIV.
When I first heard about it as a pediatrician, it was a clinical problem that was being reported from the West Coast and New York in young men, and I was a pediatrician, so I didn't think it would have anything to do with me.
Hello, I'm Mary Wakefield, the Administrator of the Health Resources and Services Administration, or HRSA. As the primary federal agency for improving access to healthcare services for people who are uninsured, isolated, or medically vulnerable, HRSA sits at the crossroads of integrating primary care and treating chronic illnesses like HIV and AIDS. I call HIV and AIDS a chronic illness because as a nurse, I know that thanks to programs like the Ryan White program, people with HIV and AIDS are living longer and more productive lives. The illness has truly gone from deadly to chronic, which is really quite amazing progress. With this important advancement comes the need to effectively treat people with the disease. This is where the patient-centered medical home that integrates HIV/AIDS care and primary care plays a critical role. Having multidisciplinary teams of practitioners, nurses, doctors, social workers, dietitians, pharmacists, and others, all treating the whole patient with culturally competent care is vitally important. Thanks to the investments and expansion of services that HRSA has made to the community health centers through the American Recovery and Reinvestment Act and the Affordable Care Act, this integration of care is thriving. Consistently high-quality, accessible service for people living with HIV and AIDS is what we're aiming for at HRSA. And I think with important investments being made through this administration, we're making real progress. But you don't need to take my word for it. Let's listen to those on the front lines of care and to the patients that they serve.
Our HIV practice lives within a larger primary care clinic where we provide care for children from birth through 21. First and foremost, the needs of infants born with HIV, of children living with HIV, of the families loving and caring for them, is to have a pediatric practice, a pediatrician, a primary care practice that is welcoming, that is trustworthy and responsible, is willing to be there through thick and thin to help them with whatever comes forward.
Greater Baden started as a rural clinic for the tobacco farming community in southeastern Prince George's County. The board of directors had a larger view very early on and applied for one of the first Title I grants, at that time was called Title I, to provide care for patients who had come back to the rural area in the beginning of the HIV/AIDS epidemic. Within less than 3 years, there were 50 patients receiving care at Greater Baden. So the impact of the epidemic has always been in the forefront of our consciousness because we saw it.
Unity was one of the initial recipients of HIV money in the district, and we have been working in that field ever since. We have increased the providers that we have that specifically work with those people that have HIV. So here at Unity, we have been working diligently to ensure that there are a number of ways to assist the person that is impacted by this disease.
The Star Track program is very unique because it really serves a very unique population in the city of Baltimore and in the state of Maryland. We specialized in very high-risk youth who are homeless or runaways, or who are those youth who don't have a medical home. So we are a unique site when we take people into the community, especially young people, youth advocates who go out to the community, to be able to discuss those topics openly, which is what allows them to feel at ease to be able to get HIV testing and services.
It was a very much struggle for me. And about this time last year, I was very, very sick, very sick. And as time went on, and went to come to see the doctors, and I'm better now.
Well, health centers currently treat over 95,000 people across the country that have HIV and AIDS. We also do testing for almost 700,000 people. Most recently, however, we have put out additional guidance to our health centers in support of the National HIV/AIDS strategy to encourage health centers to look at what they are doing in terms of prevention, what are they doing in terms of testing, and most recently, what can they do in terms of care and treatment, not only on-site in a primary care setting, but also what linkages can they support and develop with other HIV specialty providers.
A medical home is a place where people can come and get care regardless of what they have. So people with HIV can get care in a place where they get their primary care, and it's just one other thing for which you're treated.
When there's a medical problem, when there's a social problem, when there's a crisis and you don't know what to do, you should feel like you've got a medical home, a primary care home to go to say, I need help.
The Ryan White population that we have served has largely wanted to remain anonymous. So their ability to get services in a place where everyone comes for services allows them to receive the services without revealing to their neighbors information that they don't want their neighbors to have. The other impact is it helps us to provide the more inclusive services.
Well, people that come here now can get a host of services, and the person with HIV now doesn't feel isolated, like, you know, this is where I have to go. Am I getting the right service? Are they giving me the best service?
There is a true continuity of care. So we find them in the community, we do their HIV testing and their counseling and their prevention right at their sites, and then we link them immediately to care. So we have a 24/7 service to be able to link the youth to care.
HRSA, in the last several years, we've made significant investments through both the Recovery Act as well as most recently through the Affordable Care Act to support the expansion of capacity of health centers to actually serve more patients. We've built new facilities, we've provided operating grants to help expand their capacity to see more patients, and we've done recently a big push to have health centers become patient-centered medical homes.
The Recovery Act funding has helped, and the capital improvement funding has helped tremendously. At our site at Upper Cardozo, they've been the recipients of $9.5 million in capital improvement funds. That has helped to expand the center, bring on new providers, increase the access to the community, and provide us an opportunity to create an atmosphere that patients, HIV and the community, will view on as a healthy environment to come.
Prior to the renovation, the infectious disease doctor had to split clinic time with the primary care doctors, which meant they were only allowed to be here certain times during the week. Now with the renovation, there's more room, there's more office space, there's more space for patients. The flow and the efficiency is a lot better.
we have had success in that people are living longer. One of the other successes we have had is with those children that were perinatally infected. These are children who were born with HIV. Early in the epidemic, they died within, well, they were still in childhood, but now they're living into adulthood and actually starting to have their own children.
Well, I've been a part of this clinic for more than 23 years. Well, my doctor said she was my doctor when I was like 18 months. So for 22 years, I've been coming here. I've had the same doctor for 22 years.
You know, the patients we have now who are in their early 20s who were born with HIV in the late 1980s. And many of them are orphaned because back in those days in the US, parents were dying. And for many of them, we in the clinic are the only people who've known them since they were babies, the only adults who've really been in their lives since then.
Personal relationship is very important to me in this clinic for the simple fact that I've been at this clinic for a long time, and I want to say that the clinic is 90% of my support system.
We are huge advocates for preventive care. We spend a great deal of time counseling our patients and their families on the importance of behaviors that will minimize their risk for not just HIV, but also their risk for other sexually transmitted diseases and comorbidities.
So everything is confidential and our secret, we share secrets and they stay secrets. That's how my peers and I stay comfortable.
Even though we've come a long way, there's still some stigma associated with being HIV positive. And so a lot of people they hide their status. And so it's hard for them to take the medication because they're afraid that somebody may find the pills at home. And so they may store it in the car or at work. And then if they're not able to get back to that location to take the medication, then it's hard for them to take it.
I think the biggest thing with the adherence issue with not taking the medicine is the denial of having the HIV, and especially with our newly diagnosed kids. Until they accept that they have it, HIV, it's really hard to treat it. So part of the job of the social worker is just talking and working with them and gradually getting them to accept the diagnosis and incorporate it into, their life.
I come to the hospital every day to do DOT, which is direct observation therapy. So every day I come to swallow my pills, Monday through Friday, every day.
The increase in clinicians serving in the National Health Service Corps, many of them in community health centers, as well as in Ryan White program clinics, is another investment in providing the care that these and other patients in underserved areas need and deserve.
At Unity and throughout the country, community health centers would not be able to operate without the National Service Corps programs. They allow community health centers like Unity to recruit highly skilled, highly talented clinicians into underserved communities. So the collaboration between the two is essential for us to meet the needs of the underserved, not only here in DC, but throughout the country.
The President released the National HIV/AIDS Strategy in July of last year. There are 3 primary goals of the National HIV/AIDS Strategy.
Reducing new HIV infections, improving care for people living with HIV/AIDS, narrowing health disparities. These are the central goals of our national strategy.
So your cholesterol, I wanted to check this time.
Having a simple quick doctor visit, how are you, write a prescription was not going to be a model that could succeed in treating people who were living with this disease. And that this really is a team effort.
It is impossible for an infectious disease specialist to provide the total care for all of their patients. They have to work with the primary care physician and the other practitioners who interact with them.
And by working together, I can focus on the HIV issues, which are complicated by toxicities, as I mentioned, high cholesterol, pregnancy. So I can focus on those issues that patients with HIV have at the time that I see them and be comfortable that their other issues, hypertension, diabetes, have already been addressed by their primary care provider.
I think HIV again has kind of led the way and shown us that you get a lot back. There's a big return on investment when you have a model of care that provides the comprehensive, coordinated, continuous care of people who need and deserve that.
I mean, the staff is just wonderful. I feel like this is my family, you know. I feel like when I walk in the door, I feel like a celebrity.
I think this fulfills a big need. You know, there are people that are here because they love it here, and they know that their providers care, and I think it comes across.
There are HIV treatment options available, especially for pre-exposure. Prophylactics, pre-exposure prophylactics is used for high-risk populations, those in populations of people, men who have sex with men, sexually active men and women, injecting drug users, so IV drug users, in serodiscordant relationships. A serodiscordant relationship is a relationship where one individual actually has HIV and the other does not. Post-exposure prophylactics is given when there is an occupational exposure, a non-occupational exposure, and also a sexual assault. The one that's become widely used currently is Truvada. You may have seen some of the commercials for it. And it's a combination drug of tenofovir and emtricitabine. And it's a pill that can be taken once daily, and it actually prevents HIV. It reduces the risk of HIV infection by up to 92%, and the effectiveness, of course, differs based on anatomy and differs for each individual. Post-exposure prophylaxis is given for adults and adolescents that are greater than the age of 13. So the preferred method or preferred alternative will be a 3-drug regimen consisting of Truvada, raltegravir, or dolutegravir once daily. Another preferred method is, again, the raltegravir and dolutegravir, and that's for adults with renal dysfunction. So the first one that I mentioned is actually for adolescents and adults 13 years of age or older, including pregnant women with normal renal function. So with someone with a decreased renal function or renal dysfunction, they're actually going to change up the dosages a little bit. They're not giving quite as much, or they're changing out the specific medications to try to preserve renal function. So for children ages 2 to 12 years old, the preferred method is a 3-drug regimen consisting of the tenofovir, the emtricitabine, and raltegravir, with each drug dosed to age and weight. So the what I really want you to focus in on for this post-exposure prophylactics is that it's not necessarily just one drug that's given. It's a combination of drugs to prevent that seroconversion or to stop HIV from combining with the CD4 cells at that membrane level. So review this in your book. It's table 5. And for HIV, I believe it's chapter 19 in your IGI. So one of the goals, according to the Health and Human Services, their goal is a 75% reduction in new HIV infections in 5 years and at least 90% reduction in 10 years. So far, with these new drugs that they've come out with, it is actually helping people to live longer with HIV and also preventing the risk of exposure for people who are in a high-risk population, either they're sex workers or men who have relationship with men, or they're in a discordant relationship, a serodiscordant relationship. So where one of the individuals has tested positive for HIV and the other individual has not. So unfortunately, we are in part of that high-risk population because of being healthcare workers. But the incidence of needle stick injuries have drastically decreased, especially with the institution of needleless syringes. So when we're actually starting IVs or putting medication in IVs or even doing IV push medications, we don't have to introduce a needle into the port. We're actually just using needleless syringes. So exposure of non-intact skin mucous membranes to blood and bodily fluids, that still can occur. Of course, we're encouraged to use our PPE when we're dealing with people who have when we're dealing with a higher risk, of contracting infectious disease. So standard precaution is the best prevention. Of course, that's that PPE. And then also, if there is an exposure, we can too take the post-exposure prophylactics. So interprofessional collaborative care. So it requires an in-depth assessment. We have to notice what's going on with our patients. Try to get a candid history, a past medical history, and we want to do an in-depth physical assessment, especially if someone has already tested positive for HIV. We want to do an assessment and see if they've been exposed to bacterial infections, fungal infections, or viral infections. Ask them those questions. Have you had a cold in the last 2 weeks? Have you been exposed to people who have had a cold or the flu in the last 2 weeks? Because we want to minimize their risks for those opportunistic infections. And 2, we want to do a good physical assessment and look over their body for malignancies such as a Kaposi sarcoma and malignant lymphomas, invasive cancers, and also HPV. When you have a diagnosis of HIV, of course, your immune system is suppressed, so it makes you more susceptible to those opportunistic infections, especially sexually transmitted infections. So 2, we want to assess them for endocrine complications because people with HIV have metabolic dysfunctions. They have that metabolic disorder where their body is not properly using glucose, and they're have increased deposits of adipose tissue and increased risks of high cholesterol. As one of the videos that was in the we watched earlier, that are some of the things that the primary care physician needs to do a surveillance on them quite often to see how their cholesterol levels are and if they're having any other complications. We also need to do an in-depth psychosocial assessment, see what stressors they may be experiencing, what sort of support system that they have. Also in the video, we heard one individual speak about how she was an orphan because she was born with HIV, so both of her parents were predeceased. So that's an important factor, is for them to develop good social relationships and support systems so that they won't feel alone and won't feel stressed and be more susceptible to depression and anxiety related to their status. Other signs and symptoms that we need to look for is the AIDS dementia complex, the AIDS wasting syndrome, and also skin changes, as well as kidney problems. Here we see some clinical manifestations of AIDS. So we have, for immunological, they have a low white cell counts. That CD4 count, again, is below 200 units per liter, or mmls, or millimeters per liter. And they have opportunistic infections, lymphadenopathy, they have fatigue. So their skin is poor wound healing. They have skin lesions. They suffer from night sweats, respiratory. They have a cough that's persistent, shortness of breath, gastrointestinal. They can have diarrhea because of opportunistic bacterial infections, as well as side effects to some of the antiviral medications that they can be taken. And weight loss, nausea and vomiting. Their central nervous system can be affected with confusion, the AIDS dementia that was mentioned, headaches and visual changes, and actually personality changes too. They can experience a lot of pain and seizures as well. So some of the opportunistic infections that can plague our patients that are HIV positive and their CD4 count is decreasing is the pneumocystis carinii pneumonia, toxoplasmosis or encephalitis, cryptosporidosis, and that tends to affect their GI system. Fungal infections, they have the oral candidiasis, the stomatitis, and esophagitis, and vaginal candiditis too, so they can have in their mouth and their esophagus as well as their vagina, those fungal infections. So bacterial infections like Mycobacterium complex, and also they can be exposed or more susceptible to tuberculosis. Viral infections such as cytomegalovirus, herpes simplex virus, and the varicella zoster virus. So if they haven't, that'll be one thing to assess when you're doing a physical assessment and getting their past medical history. You can ask them whether they've ever had chickenpox when they were younger. And of course, that would increase their risk of getting shingles as well. So some malignancies that are seen as a clinical manifestations of AIDS is that Kaposi sarcoma, non-Hodgkin's lymphoma, invasive cervical cancers as well. And that AIDS dementia complex actually affects their cognitive, motor, and behavioral manifestations or behavioral impairments. And that happens in 70% of the cases of AIDS or clients who develop AIDS. So this will be a good one to review, along with some other handouts that I posted on Blackboard as far as the clinical manifestations of AIDS. Usually with me, If there's a slide on the PowerPoint that has several different things, I can give you a hint to say that it may be on one of your select all that applies for a future test. So laboratory assessments, again, they're going to review their lymphocyte counts, their CD4 T cell and CD8 T cell count. They're going to perform antibody tests, the ELSA, the Western blot. Again, some home tests that can be given are the OraQuick, which is an in-home HIV test. They will have viral load testing done and biochemistries like their CBC, stool testing, and biopsies. The three main ones are your CD4 T cell antibody tests and viral load testings that will be conducted. So here we can have a point to educate our patient on what their lab results mean. So we want their CD4 count to be high. So when we're reviewing their labs with them, we want to, give them the difference and what that means for them as far as their risk for opportunistic infections. So if they have a high CD4 count, then of course that will decrease their risk for those opportunistic infections. A high viral load test, of course, that's showing that the virus is actually doing more damage to their immune system and it's actually overwhelming it. So some other tests that are important is drug resistance tests, because each individual is different. Some individuals can take some medications and it will help them with their viral load, keeping it under wraps and keeping it at a low count. But for others, certain medications won't work. So doing a drug resistance test will help them to determine which drug works best for them. Tests for other infections, of course, we want to always do surveillance for our patients with AIDS or HIV prior to it developing into AIDS. We want to make sure that they're not being exposed to any opportunistic infections. We want a complete blood count because we want to be on top of their electrolytes, their platelet counts, their cholesterol levels, their liver enzymes, their kidney function, to make sure that none of those systems are being affected by the virus and actually bringing down their immune system even more, making them more susceptible to those opportunistic infections. So our blood chemistry test, of course, it measures several different chemicals in the blood, like the health of your organs, like I just mentioned. So that's one way that we can break it down for our patients and let them know exactly why they need the labs done. Again, as I referred to the video before, that's one of the reasons why it's really important for HIV positive individuals to be involved in a patient-centered care program so that they can be cared for not only with their HIV complications, but as a whole individual. And that would give them a better prognosis in the end. So viral load testing measures the presence of HIV genetic material or other viral proteins and not the body's response to the virus. So it's used to monitor the progression of the disease and evaluate the effectiveness of treatment. So an analysis. So they have a potential for infection. That's one of the nursing diagnoses that we can equate to a person with HIV or AIDS. Inadequate gas exchange, pain, inadequate nutrition, diarrhea, potential for reduced tissue integrity, cognitive decline, and potential for psychosocial distress. Some additional nursing diagnoses is reduced skin integrity, confusion, reduced self-esteem, potential loss of social contact. So some of the ways that we can prevent infection is drug therapy. Antiretroviral drugs are multiple drugs used together in combination. So combination antiretroviral therapy, that's CR therapy. So NRTIs are nucleoside reverse transcriptase inhibitors. Those are some of the medications that can be used. NNRTIs are non-nucleoside reverse transcriptase inhibitors, and that works at a certain point where the virus tries to attack the CD4 cells. So you'll just have to revert back to that picture that I put up in the first few slides about how the drugs actually work in preventing the virus from attacking the CD4 cells. So your PIs are your protease inhibitors, and then you have your integrase inhibitors, fusion inhibitors, and entry inhibitors. And two, I've noted that you can see the charts in IGGI. And the best practice charts is actually hyperlinked, so you can look at them. As far as this goes with this slide, I would say to review that slide with the HIV life cycle and have an idea of where the specific kind of medications work to stop the life cycle of HIV. So here's a review of enhancing the gas exchange, and that could be done through drug therapy, and that's related to the PCP infection, the P. gyrovecii pneumonia, and treatment for that, if they were to have this nursing diagnosis, would be bronchodilators, antibiotics, and then we want to provide them comfort and respiratory support and rest and activity changes. So we want to monitor them for fatigue and pace and prioritize their activities. So managing pain, we want to provide comfort measures, give them a pressure relieving mattress, like a air mattress such as the Hill-Rom Versacare mattress, a warm bath, massage, hot and cold therapy. And then when we need to reposition them, we're going to try to use a draw sheet to provide comfort so they're not getting any friction or shear injuries. We're going to give them drug therapy, the antiretroviral, NSAIDs, Lyrica or pregabalin, amitriptyline possibly can be used, gabapentin for nerve pain as well, phenytonin for any kind of seizure activity that could be happening, or and some opioids as well to manage their pain. Complementary and integrative therapies can include acupuncture, massage, guided imagery, distraction, progressive relaxation, and biofeedback as well. And I will post these slides with the additional notes to them so that you can have them as a point of reference for your studying as well. So enhancing nutrition, we want to again give drug therapy with ketoconazole or fluconazole, IV amphotericin B, and that is to reduce the side effects, or possible side effects of these medications could be nausea and vomiting. And we want to provide mouth care and then give them ice trips. Nutrition therapy, we want to monitor their weight, their intake and their output, their calorie count. And we want to make sure that we give them a high calorie intake and a high protein diet. So high calorie and high protein diet. We want to provide mouth care. And when we do provide mouth care, we want to be sure to use a soft bristle toothbrush and increase their fluid intake. And then we want to add in those complementary and integrative therapies as well. So restoring skin integrity, we want to minimize diarrhea with anti-diarrheals. We want to keep their perineal area clean and dry. We want to restore their skin integrity with antiretroviral drug therapy, analgesics for comfort measures, and appropriate skin care. To enhance their cognition, we want to reorient them to where they are and what's going on, person, place, time. We want to provide them drug therapy with antidepressants and psychotropics and anxiolytics if necessary. We want to provide safety measures, assist them with their ADLs, and make sure they are if they are a fall risk, we want to provide fall precautions as well as seizure precautions. We want to give them support, include their family and their friends if allowed in their care, and also make sure they have a consult with a social worker in the event that they need other assistance with housing, food, clothing, and even getting their medication. We want to address their psychosocial distress. We want to provide a climate of acceptance. We want to promote a trusting relationship, encourage the expression of their feelings, identify positive aspects of themselves, allow for privacy if needed, and then try to help them to avoid isolating themselves or us isolating them as well. We want to encourage their self-care within their limits and then encourage independence so that they can have a sense of control and dignity. And we want to use guided imagery as well, help them to reflect on happier moments in their life, to one, minimize pain and distract them emotionally from what's going on, especially if they're at the point where they've advanced to AIDS and they're having a lot of discomforts associated with that. So care coordination and transition management, we want to make sure that if they're in the hospital, happen to be hospitalized for opportunistic infections associated with AIDS, then we want to provide them the best care that we can while they're there in the hospital. But also we want to make sure that social work and other PT and OT consults have been made so when they transition to home, they can have great care as well. And that's one of the things, again, in that patient-centered care program that they do. They actually help them when they're in the hospital and then follow them on with home care, with home health aides if they need, social workers that'll come out and visit the house. One of the things too we want to do is educate them. Educate them on how to eat a healthy diet. So they might have a nutritionist consult. Help them to recognize the importance of taking their medication every day, that they cannot miss a dose of medication at all, because that will increase the risk of the viral load starting to increase and the virus itself to start reproducing. So we want to make sure psychosocially we prepare them, help them with therapy, a psychiatrist if necessary, and other healthcare resources to get them on the road to recovery or road to maintaining their care and managing their care with their status. So the overall outcomes for care of our patients with AIDS are to maintain the highest possible level of function for as long as possible. We want to make sure that we reduce their risk of infections and help them to maintain a quality of life and dignity during the course of their progressive illness. That's most important. So we have a couple of review questions here for you. So a 30-year-old man with HIV is admitted to the acute care unit. Which assessment findings does the nurse recognize that may indicate that the patient currently has AIDS? So you could select all that applies. So Kaposi sarcoma, which happens to be one of those AIDS identifying illnesses. And so is their HIV positive status an indication that they currently have AIDS? No, it is not. Simply because a patient is HIV positive, that does not mean that they have AIDS. A person who has AIDS is always HIV positive. Wasting syndrome, so that is one of those AIDS AIDS defining conditions is that wasting syndrome. The esophageal candidiasis, that too is one of those AIDS defining conditions. Persistent generalized lymphadenopathy, that is not necessarily a characteristics of AIDS. Persistent generalized lymphadenopathy is a characteristic of an HIV infection only. And you can go back to our man in slide number Slide number 29, the clinical manifestations of AIDS. That will show you what those AIDS defining conditions are. Okay, let's see the next slide. So the patient is very weak. During this admission, he has experienced anorexia, painful swallowing, severe diarrhea, and occasional vomiting. Frequent mouth care is to be delegated to the unlicensed assistive personnel, so your nursing assistant. So what instructions should you give the nursing assistant? So if they're having painful swallowing, right, that can suggest that they have the oral candidiasis, correct? So when we're instructing the nursing assistant to help the patient with oral care, we want to make sure that the patient rinses his mouth with normal saline every 2 hours, right? Use a soft bristle toothbrush and remind the patient the need to drink plenty of fluids. And also, the nurse assistant will need to notify the RN of any mouth pain, because we can give them some medication, some oral viscous lidocaine to be administered to help with that pain. So next, after 8 days, the patient is being discharged home, where he lives with his mother and father. The nurse is completing the discharge instructions for him and his family. What infection control teaching should the nurse provide to the patient and family? So the answer to this is, when the patient is discharged, one of the most important things for him or her to remember is standard precautions and good hand washing. When at home, the patient and family should have a good understanding When at home, the patient and family should have a good understanding that body fluids, including feces, vomitus, Urine, blood, or any other body fluid should be cleaned away with soap and water, and the area disinfected with a 1 to 10 bleach solution for at least 5 minutes. If bed linens or clothes become soiled, they should be washed in hot water with 1 cup of bleach added per load of laundry. Dispose of needles and other sharps in a labeled puncture-proof container to avoid needle stick injuries. So for a complete list, you can see your chart on chapter 19 in your book, which is on page 344. That's chart 9-8 for more of those things to do with the family to educate them on home care. As the nurse is talking to the patient comments that he does not know why he must live with such a horrible disease and state that he knows he will die soon. What is the appropriate nursing response? So in this instance, the nurse should provide therapeutic communication and active listening. The patient should be encouraged to openly express his feelings about the disease. If the patient states that he has thought about taking his own life, it is the responsibility of the nurse to notify the patient's healthcare provider. So we always want to put the patient's safety first. So we're going to do some other questions here. A patient with AIDS is having difficulty maintaining body weight. Which nursing interventions are most appropriate for this patient? Select all that apply. So do we want to encourage the patient to drink at least 1 liter of fluid per day? Well, he needs to be drinking more than 1 liter of fluid per day. We want to make sure that we collaborate with the dietitian. Yes, to make sure that the patient is on a high-calorie, high-protein diet, right? And we want to provide foods that are in high-calorie. Yes. Encourage low-fat food choices. Yes. Provide 3 large meals a day. Someone who is diagnosed with AIDS or having difficulty maintaining their body weight, you can provide those meals, but if they're not, they have a decreased appetite, then it's not going to do them any good. You should probably consult with the dietitian and the patient themselves to see what foods they like and try to encourage them to eat those high-calorie, high-protein foods. And we want to ensure regular mouth care. It's very important. So small, frequent meals, as they are often better tolerated than large meals, and providing regular mouth care can improve their appetite. So we have a true or false question. Genetic testing has no benefit in the treatment plan of a patient with HIV. Is that true or false? Well, that's false, because with HIV, a genotype test can be used to determine whether any mutation exists in the strain of HIV that has infected the patient. And this is useful before starting any antiretroviral therapy to learn whether the patient is infected with a resistant strain of HIV. So this test will help the clinician choose which antiretroviral drugs are likely to be effective against viral replication and to which drugs the virus is resistant. So it increases the likelihood that the medication that the patient is put on is going to be effective in reducing the viral load and stopping replication of the HIV virus. A patient is fearful that he has become infected with HIV. The nurse recognizes which as the first symptom associated with possible HIV infection. So which is the first symptom associated with possible HIV infection? So that could be an opportunistic infection will not be a first sign of HIV. That would be a sign for AIDS, right? Fever, night sweats, and muscle aches can be a possible infection with HIV. Those are some of the symptoms that are listed. So reduced numbers of CD4 and T cells, that would indicate an AIDS, the progression to AIDS. So that is it for our HIV and AIDS content. If you have any questions, please feel free to email me, samantha.mccoy@rccc.edu. Also, don't forget to go over the PDFs that I placed on Blackboard, and I will be providing you with a general study guide as well on HIV. And that's it. It was wonderful talking with you guys. I hope you were able to hear me clearly. If there's something that you didn't hear or understand and I didn't express or elaborate on enough, please, of course, send me an email. And you can also connect with me on Teams, Microsoft Teams as well. Okay, thank you.